So we're going to talk about PCIT. It's a huge topic, a lot of ground to cover. And I structured it I put it at the beginning of the year because I feel like on the inpatient unit and during your outpatient assessment, emergency room, you guys might have kids who you might want to refer for PCIT. It's kind of a new thing, I think, for child psychiatry. So it's good. I feel like it's a good thing for you to be familiar with, so you know what you're referring kiddos to. I think some of you are already familiar with PCAT, parent-child interaction therapy. I will mention to you other therapies for young children because PCAT is not the only one. It is evidence-based treatment, but there is several other ones that you can definitely consider when you're seeing young children in your clinic. So this is what we're going to talk about. I'll briefly mention about assessment of young children. We will have didactics devoted just to assessment and children observation because it's so different for young children as opposed to teenagers or even middle school children. We will talk about typical disorders that we see in young children, especially with externalizing symptoms. We will mention all kinds of evidence-based therapies for young children. I'll tell you a little bit about Young Child Clinic here at Mayo, and then obviously we'll mostly focus on PCAT and then how typical course of treatment in PCAT looks like. So when you refer people to PCAT and they ask you all kinds of questions, you'll know how to answer them. So young children are really fun to work with. My favorite patient population. Can't think of doing anything else than working with young children. However, there are a number of challenges when we work with young children. The number one challenge is that they are a little bit like a black box. We can't just have them sit on the couch and ask, you know, how are you doing today? How your mood has been over the past 2 weeks, and how are you sleeping? Because they would not know how to answer those questions, and they would look at you like you are crazy, and the parent would also look at you weird. So the assessment that we do with young children is very different than what you are used to when doing assessment with teenagers or with adult patients. And what we do is we use a lot of toys. My favorite one is Dollhouse that now I'm not able to use because of COVID, but I still have you know, some basic toys even with COVID. I have magnetic blocks, and I have cars, and I have people, and oops, sorry. That's the video that I'm gonna play to you in a sec. Uh, so magnetic blocks, plastic, people, cars, things like that, things that are easy to clean. Are awesome toys, and you would be surprised how well kids are able to play with those toys, how interested they are. I had a family where parents asked me, is this the only choice that you have? And then their child was easily entertained and play for 45 minutes with the limited choice that I had. And even with the magnetic blocks, the child can still, you know, build a house. And you can use people to play different scenarios and assess children in that way. So that's a big part of the assessment, right? Like how structured is the play, how well the child transitions from one activity to the next. What I oftentimes ask parents to do, especially if I'm assessing family for fitness for PCIT, is I might ask them to do 3 different tasks, which is part of DPIX that I'll explain to you in a sec. I'll ask them, well, first 5 minutes, please play. Just follow your child's lead. Then next 5 minutes after that, tell your child, now we're going to do what I would like to do, what mommy wants to do, or what daddy wants to do. And I just want to see how the child is going to transition from that free play activity, mom or dad follows their lead, to a little bit more structured activity. And I suggest to parents from playing with magnetic blocks that invariably is really fun to children. I ask them maybe draw a picture of a family, ask your child to draw a picture of a family, which is oftentimes a little bit less fun. And then the last 5 minutes, I ask the parents to ask their child to clean up at least one of the toys. And so that is extremely informative for me because I pay attention to what the child is doing, but I also pay attention to what the parents are doing. How are they asking their child to clean up? Are they just asking questions gently? Would you put all the toys in the box? Could you, mommy's gonna help you. Let's sing a song. Look, I'm putting all the toys. Or is the parent, raising a voice and getting really angry and irritated with the child because they're not listening right away, right? So that just 15 minutes gives me a ton of information right there, and allows me to assess their fitness for PCIT, or how much they would benefit from PCIT. In terms of history taking, I always keep in mind that it should not be only cataloging all of the child's misbehaviors, right? Oftentimes parents come to you and they just want to tell you everything that Johnny is doing wrong, right? And nothing else. There's no positives, right? You also want to ask family always about traumatic events, because that oftentimes contributes to difficult behaviors. Measures, general measures like CBCL or BASC are helpful. And as you know, they're broken down into various domains, so that kind of gives you a nice idea of what's going on. Is it anxiety? Is it ADHD that's kind of driving the symptomatology? Observation at preschool or daycare, of course, most of the time impossible. But what I do is, for a lot of my families, I do talk to daycares or preschools on the phone, and they give me a lot of valuable information. Sometimes behaviors are an effect of just not a good fit for a particular child in terms of daycare or preschool, and maybe inexperienced teacher, or maybe too many children in a particular daycare, or maybe there are very strict rules around sitting in circle time, and the child is not ready for that. And therefore, there are a lot of behaviors. So most preschools and daycares, they're extremely grateful for a phone call, and you're kind of trying to problem solve with them in terms of behaviors. And then you look at factors in the child, so emotion regulation, increased arousal. We can, do you guys know what age we can diagnose ADHD according to DSM-5? What are the criteria for young children? So actually 3 years old, we can already diagnose ADHD, 3.5. However, it's oftentimes really hard to say Is it typical 3-year-old behavior, maybe a little bit more on a hyper side, or is it already ADHD, hyperactivity disorder? And so sometimes people want to wait a little bit longer before they make the diagnosis. And then the other thing is, the recommendations, and we'll talk about it, for the younger children below 5 is to try therapy first before jumping to medications. You want to think about all kinds of medical factors. Developmental delay is something very important to think about. Obviously, trauma, PTSD, neglect, family disruption. For young children, any disruption, even minimal, can cause a lot of behaviors like changing their favorite nanny, or a different teacher at preschool or daycare, or their best friend suddenly left, or the family moved to a different house, a new child being born. All those things can have tremendous impact on the child's behavior. So you always have to ask about all those things. Experiences of a failure by the child, we never think about it, right? The 3-year-old, like, what kind of failures they might perceive, but definitely it's something to think about. ODD is not my favorite diagnosis. People who know me, they already know that. It is a bit of a wastebasket diagnosis. Young children, they have a very small repertoire of ways to respond to stressors, and they can't talk about it. They can't, like I said, they can't sit on your couch and say, Dr. Miller, I am really struggling with moving to a new house, and I don't like, my new room, or I miss my nanny. And so the only way they can manage the stress really is by having tantrums. And so, it's just really easy for young children to meet criteria for ODD diagnosis, and just kind of putting that diagnosis, I feel like, makes us a bit lazy, because then we don't try to dig in and try to find that underlying reason for those young children to behave in such a way. Are they anxious? Do they have ADHD? Are they struggling with environmental uh, reasons? With COVID now, I've been so overwhelmed with numbers of referrals, and young children are really struggling with changes that are happening in the context of COVID. So definitely environment plays a huge role in terms of affecting young children. So as I mentioned, there are a number of therapies for young children. There is a triple P positive parenting program that is for young children, but can be used also for slightly older children. There's child parent psychotherapy that is for children 0 to 5. It was developed mostly for children with history of trauma. I do that therapy here too. I like it a lot. It's much longer than PCIT. I think the average number of sessions is like 30. And that's just the average. And it can be also offered to parents who are expecting a child. So that's really cool. It's evidence-based, and like I said, mostly focused on trauma-focused CBT. I think it starts at the age of 3 and obviously goes all the way to 18 for pediatric patients. And then we have PCIT, we'll be talking about it, helping the non-compliant child. And then play therapy, circle of security, and zones of regulation are therapies that don't have enough evidence to reach the evidence-based, but they are used quite frequently. The zones of regulation are oftentimes used by occupational therapy. I'm sure you're familiar. I think they use it on our inpatient unit sometimes, red zone, yellow zone, and green zone, kind of how your engine is running, that sort of language. I like it. And and obviously play therapy. I think all of you are using elements of play therapy. So So Young Child Clinic, actually the age criteria changed now because I'm doing CPP. So technically can see patients 0 to 7 years old. I might change the age range a little bit, change the upper age criteria to 5 because just so many patients being referred, and the wait list is getting longer. But children with ADHD, ODD, anxiety, sleep and feeding difficulties, obviously history of trauma, attachment difficulties, parent-child relationship issues, and I do assessments 3 days a week, Mondays, Wednesdays, Fridays. So if anyone wants to join, just observe assessments, feel free anytime. I actually never had a family who refused a fellow join. Now I'm gonna only focus on PCIT. So all the slides now are going to be devoted to PCIT, and I'm happy to share the slides with you too, guys. Any questions so far about the assessment? Okay. As I mentioned, PCIT is evidence-based. It's a behavioral training, a parent training program. The cool thing about it is that it allows a therapist to coach parents in real time. So a parent wears a bug in the ear, and the therapist coaches parent through that bug from behind a one-way mirror. With COVID, you can still do, obviously, I've been doing in the office sessions with parents wearing the bug in the ear, no problem. But also there's been some research even prior to COVID on internet delivered PCIT, where essentially the screen of the computer is a one-way mirror and parents wear headphones at home, and it works actually really well. I do both. I do internet PCAT and I do in-person PCAT, and I enjoy both. I actually really like doing the internet PCAT because it allows me to kind of have a window into what's going on at home, and how especially when we do the second part of the treatment that I'll talk to you about in a second, how the timeout goes at home. And so I can immediately help family, correct anything that's not going as it's supposed to. And in the office, obviously, that's a little bit harder because I'm just being left with what the parents are telling me what's going on at home. Parents are coached in 2 sets of skills: CDI, so child-directed intervention, and PDI, parent-directed intervention. It's a short-time intervention, which that's what's really nice about PCAT in comparison to a lot of other therapies. Most of my PCIT families were done in 8 sessions. And so that's really nice because 8 weeks and you're done. And most families don't need to return for a booster session. So that's also really, really nice. So let me play the video that I hope that Can you guys hear it? Okay. Sometimes I have to do...
I don't think we can see it also.
Oh, you can't see it? Okay.
Mm.
Okay, let me do stop sharing. Worst case scenario, I can just send you those videos. Okay. I figured it out with other groups, so I'm sure I can figure it out. It just requires a little bit of... Can you see it now? Okay. Let's see if that works. Can you hear it? Were you able to? I just played like a little bit.
We couldn't hear.
Okay. Were you able to hear anything? No?
No.
I think, Dr. Romanowicz, this happened to me before. I think when you share the screen.
Yeah, I think you'll be able to do it, to hear it now. Let's try.
And abuse.
Perfect.
When 2-year-old Richard looks into his mama's eyes, he knows the true meaning of tender, loving care. His older brother Doyle hasn't always been so sure.
He was so afraid. He was in the corner, shaking, back then, scared. He would run to a stranger before he would run to me.
An 18-year-old single mother with limited parenting skills, Tammy Victor was raising her children in the same abusive way she had been raised.
I slapped my son. I threw him at a wall. I kicked him, punched him, slapped him. All those scream, holler, cursed at him, threw him around. All those mean things to that boy.
Ultimately, Tammy herself called the police and asked for help. What she got was 6 months in jail for child abuse. Richard and Doyle were put into foster care until the courts were satisfied they would be safe with their mother.
So I went to go visit my kids, and they were just sitting there looking at me, laughing. Hi, Mama, I love you, like that. I'm like, why do they love me? What? How can they love their mom? After all I put them through, how could I get love back from them?
If you're 4 years old, regardless of what your mom or dad does to you, you still love them, you still need them. You don't just need them as a figure, you need them every single day in your life.
Like Tammy, most of his clients are sent to him through the courts. It's a last-ditch effort to get their kids back.
We had to change the relationship, and we had to fundamentally change some of the things that parents do with their child to make them be better parents.
Mommy has something to tell you guys, okay? Now, this is special playtime, okay? And special playtime, we play nice with all the toys.
This one-on-one therapy session uses a traditional parenting model called PCIT, Parent-Child Interaction Therapy. Urquiza hopes the basic parenting principles of PCIT will teach Tammy a better way to get her kids to behave.
You need to praise your child for the things that they do or that are appropriate. You need to describe appropriate behavior, give them a lot of attention for what they're doing that's okay and appropriate. And as soon as they do something that's not appropriate, then to ignore that behavior.
You might want to go into an ignore and start playing with Doyle, and gosh, I'd love to play with Richard if he were sitting nice at his seat.
Yeah, if Richard was sitting nice in his seat, he could play with us.
Through an earpiece, Tammy is being coached by a therapist to praise good behavior and ignore the bad. Not an easy thing to do when Richard is in the midst of a temper tantrum. It's this kind of situation that used to result in abuse.
If he would come up with us and play, we could have so much fun.
Great ignoring, Tammy. Really good ignoring.
So much fun with us, but that's okay.
It's great because you are in control right now.
The research bears it out. By breaking down old abusive patterns, Tammy is helping her children build self-esteem. And as an inherent bonus, she is becoming a better parent.
You have to give them some skills, but you also have to change the quality of the relationship so that it is self-sufficient in generating a lot of the empathy, a lot of the positive attention. That's what we have to change so that parents, even when they're at their most frustrated, are still not going to hit their child.
Okay, Tammy, why don't you turn to Richard and pat him on the back and kind of rub his back and say, I like it when you're quiet.
Yeah, I know. Oh, Richard, I like it when you crying.
I'd really like for you to come back and play at the table.
I really like for you to come back and do special playtime with us.
Here's where Tammy must apply her new skills. Richard's temper tantrum has lasted a very trying 15 minutes. Can she get her son to cooperate without being physically abusive?
Would you come sit at the table for me? Oh, thank
Good
you
job,
so much.
Crazy.
Great job. Yes.
Now pull this
I think she has a really good chance to be safe with her kids in the future, to work with her kids so that they can be good, healthy kids, feel good about themselves, feel good about their mom. She's not out of the woods yet, but she's got a really good chance.
So what did you guys think? It's similar to some families that we see, actually quite a few families I can think of on One West and other places. Was there anything in the video that struck you? Or it's really, what I like about this video is that it shows you the kind of one-way mirror, life of its own. It shows you the coaching through one-way mirror, but it also shows you the chaos of the working with the little ones that I love. And for some reason, when the young child cries, I just go to like a happy place, Zen place. I don't hear it. I can coach through that to parent. I don't know. You kind of have to be a special person, maybe. So I don't know if that part is hard for you. I know it's hard for some people. Any feedback on that? Any comments or questions?
It's a really great video to help show how to put it all together in real time. Like a picture's worth 1,000 words. So it really helps understand how to do it. And what you were saying, it's cool how it shows the use of the one-way mirror too.
Mm-hmm, mm-hmm. Yeah, yeah. And crazy that the mom asked for help and went to prison for 6 months. That part also kind of strikes me. Rana, you were going to say something?
No, I was just going to say I really liked it. It never occurred to me that it also protects kids from abuse. Like it's all, because a lot of the parents that, at least that I saw with Jen, are really well-to-do parents, motivated to make their kids' life better. There wasn't that neglect piece, but it's interesting to see that it helps protect kids overall.
Mm-hmm. Mm-hmm. Mm-hmm.
Or abuse.
I think I was just struck by how hard it must be in the moment that like even just that there's couple, it probably wasn't even more than a minute of like the kid crying was making me feel worried and anxious and I don't know what to do. And then to have the mom sit there for like 15 minutes and still be running through the skills, I just can't imagine how hard that is in the moment for the parents.
Yeah, I absolutely agree with you, especially, single mom overwhelmed with 2 kids below 5. That is extremely difficult. And so, that's that's the part about PCIT that I also really appreciate, is that you have that person in your ear talking to you, supporting you throughout this process. And that is different than, for example, parenting class, right? Where you come without your kids and all kinds of different parenting strategies are being thrown at you, and then you have to go home and try it, right? But it's different to just kind of being educated on, like, try this, right? And hands-on learn in that trying moment and have that person supporting you through that trying moment, so you can really practice it and experience that you can be successful while having a support of a professional. I think that is the the biggest power of PCIT, and what parents comment a lot, you know, that it's so much hands-on. And in some ways, it also, it's very structured, but it also, because it's so much hands-on, it makes it very much individualized too, right, to their specific needs.
Can you comment on like what in this specific case made it more appropriate for PCIT versus something like CPP, since there's trauma?
Yeah, yeah, I think, well, there is an ongoing debate. There's not a lot of studies that say, you know, CPP over PCIT, especially for trauma cases, or TFCBT, right? Would be better or more appropriate. A lot of it is clinician preference or family preference, or access, quite honestly. More studies are definitely needed to look into specific phenotypes of families who would respond better to one treatment over another. But there are no studies. That's a great question. Great comments, great questions, you guys. So I'm just gonna keep going. I'll teach you quickly PRIDE skills. That's the main part of CDI, so child-directed interventions, because I think that is going to be so incredibly helpful to you when you do even your medication appointments, you know, for ADHD kiddos who are misbehaving. I know that parents oftentimes ask you during those appointments for tips on parenting techniques. I think PRIDE skills are so wonderful, and every parent should be taught them when they have a child. In CDI, so child-directed intervention part, we focus on building a foundation of nice, warm interaction between a parent and a child, because we know that just even like in this video, when a child is misbehaving, the interaction between the parent and the child quickly turns sour. And the metaphor that I use for families is, imagine, you know, that you go to work and your boss constantly tells you everything that you're doing wrong all the time. You would not be a very productive employee in that work, and you would not want to go to that work, and you know, you would probably not stay too long in such work environment anyway. And the same is with children. Children and adults, in fact, are very similar. We all respond mostly to praise and positive interactions. And so I understand that you're coming here for changing your child's behaviors. So please don't look at me like I had two horns on my head. We are going to start with changing your relationship with your child first, and really, really focus on trying to catch your child being good. That metaphor oftentimes works pretty well. Before I developed it, you know, when I would start telling parents, we're going to catch your child being good, a child who's been kicked out of 5 daycares and stabbed the teacher with a pencil, and I would tell parents, we're going to catch your child being good, they would really look at me weird. And I always kind of dangle in front of them the carrot of, I also promise you, in the second part of the treatment, we are going to address all the naughty behaviors, and I will make sure, I promise you, I will make sure that your child is going to listen to all your commands. And we're not going to finish the session until your child listens to your command. one of the therapists on PCIT listserv shared with us once that when she said it to the family, showed up in pajamas to their first PDI session because they knew that they would be there all night, and they weren't. So with the CDI, the Pride skills, every letter stands for something. It's a mnemonic. So P stands for praise. There are two types of praise, label and label praise. We have like all praise, but label praise is preferred. So example of label praise is, wow, I really love it how you guys are all so quiet today, or wow, you all are participating so well. Everybody's asking wonderful questions. Reflections. So if Rana says to me, PCIT is the best thing since sliced bread, I say, it is the best thing, then it's a reflection. Imitation, so if little Johnny is playing with crayons and drawing a picture, then I tell parents, you do that too. Or if Johnny is building a castle with magnet tiles, they are expected to do that too. That's sometimes hard for parents to just follow their child's lead. Description, or just kind of describe, you are building a castle with blocks. You're putting yellow block on top of a red block. And that's so hard for parents, just simple descriptions. It's very awkward. It is very odd. I tell them, just imagine you're a sports commentator on the radio and you're just telling me everything that your child is doing. And then the last one is enjoyment. It's supposed to be fun. And so parents are supposed to reach goals criteria. And that's in 5 minutes time. The expectation is that they're gonna use 10 label praises, 10 reflections, and 10 behavior descriptions, which is a lot. They have to talk a lot. They have to say things all the time. Imagine if you have a depressed parent, they don't say a lot. They mostly ask questions, and then there's lots of silences. And so there is a lot of coaching that's needed. The parents are expected not to use any questions, no commands, no criticism. Example of criticism are saying things like, you're so silly, you're such a stinker, things like that. So even kind of hidden criticism are something that we don't want them to use, try to avoid. We use active ignoring for minor behavior. So if little Johnny runs away from the table, kind of like in the video, the therapist coach mom to pay attention to the other child and not pay attention to the negative behaviors, not to reinforce them. So provide contingent attention. So mostly pay attention to good behavior. So little Johnny runs away from the table. I tell parents, just throw a party to yourself, build the tallest tower that you could possibly build and just talk about it. I'm having so much fun. Wow, I am building such a beautiful castle. I wish Johnny could help me. And then Johnny runs to mom, and mom says, thank you so much for running to me. Oh my goodness, you are sitting next to me. I love it when you play with me, that sort of thing. And so the session has a really nice flow. 5 minutes check in. And oftentimes parents just want to like vomit everything that's going badly, and they just want to talk and talk and talk and talk and talk. And so you want to set limits on them. There's a really nice metaphor used by one of the PCIT therapists, Cheryl McNeil. And she says that, parents, oftentimes when they come to you, they want you to kind of join you to join them in the mud of everything that's going on. But what you're doing with PCIT is you want to build a boat for them to get them out of that mud. And so you allow 5 minutes for that mud to, you know, throw, and then you set the limit and you say, okay, now let's practice. Let's build the boat. I like to keep that metaphor in mind. So there is that structure to the session. And so then let's practice skills. Go behind the mirror, 5 minutes. I code, so I literally code every single sentence uttered by the parents. If you can write it down, you code it, and they're expected to have 10, 10, 10 to reach a goal criteria and then move on to the second part of the treatment based on how they do particular day. Say they had the least amount of behavior description, I say, okay, we're going to practice behavior descriptions today. There's a kind of modeling going on in the session, and so I don't tell them, oh, wow, no, so many questions. Don't ask so many questions. I don't criticize parents. I use praise skills to help with their skills. So I only pay attention to the good skills that they have. So if the parent happens to use praise, I'll say, wow, great praise, good job, mom. And that actually helps parents who are depressed and, you know, not sure of their skills as parents. I'm going to skip that video that kind of shows typical CDI session. In PDI session, parents learn good commands. I'll send you a handout for that. There are 7 rules of effective commands. Those are direct commands. An example of good effective command is, hand me this block, please. So you want to be direct. You want to be very clear, one-step command at the time, polite. There's still please at the end. You don't ask it as a question. You want to say it with a relatively stern voice, but not raising voice. Sometimes parents are just kind of like testing the water, like, will you, you know, and the child is obviously, you know, using that to their advantage. And then if the child listens to the command right away, you praise compliance. You use timeout for non-compliance. And then there are house rules and there's public outing. I always go to our gift store, and you probably have seen me go on the way with a child to the store. The parent uses commands like, you know, in the elevator, the child is not allowed to press any buttons, and on the way to the store, they have to use their walking feet. And in the store, the child cannot touch anything. They can only look with their eyes, which is a very difficult command. And sometimes those poor little kids, they put their hands in their pockets to make sure not to touch anything. But by the end of the treatment, most of them comply. It's really nice because parents can learn how to do timeout in the public setting. People in the store know me already, so they know if timeout is needed. They're totally cool with that. We also have a sibling session. And so sometimes I have even like 5 kids in the room, little siblings, all practicing timeout. And it's just so fun to see little Johnny explaining the timeout rules to their siblings, how well they know the timeout rules. They don't miss a beat. And then there's a graduation session when I give them like a little present and a diploma, and it's usually really fun. Let me show you for the end how that PDI session goes, so you have an idea. It's probably the calmest timeout that you've ever seen. It does not go that calm in my sessions. Any questions, you guys?
You have
about the PDI or the CDI? Okay, so let me, I'll show you how the timeout looks like, and then I'll send you the presentation. Can you see the screen now with the video? Okay.
If you don't put the horse in the fence,
can you hear? Okay.
You will go sit in the timeout chair.
Now count silently in your head to 5. Okay, go ahead, stand up and help her to the timeout chair. And then you're going to tell her, stay here until I say you can get off.
Stay here until I say you can get off.
And come back and sit down. Take a deep breath, Michelle. I know that was difficult. This is a really important moment. It's a teaching session for her. You're really good. You did a nice job. She's sitting in her chair silently. Okay, this is a good time to relax. Take a deep breath. That actually went very well. She cooperated with it. She's sitting in the timeout chair. We're going to give her 3 minutes and 5 seconds here to really think about what she's done and make a good choice to come back and listen.
Never goes like that, ever.
Okay, go ahead and say to her, you're sitting quietly in the chair. Are you ready to come back and put the horse inside the fence?
Kaylee, you've sat quietly in your chair. Are you ready to come back and put the horse in the fence?
Okay, so you might need to help her with her chair. And you can just point. Small praise here, thank you.
Thank you.
Now give her a follow-up command.
Kaylee, please put the kitty in the fence.
Good.
Nice job.
Nice
Thank you for listening right away.
That was great.
Yeah, so that was an extremely easy timeout. I mean, it happens. It's rare. Oftentimes you have kicking and screaming and all kinds of things happening, and you have to go through that iteration several times before the child learns to listen. But then eventually, yeah, the timeouts look like that. Any questions about any of that? I know it was kind of a very quick overview of how PCIT looks like. It's always 3 minutes and 5 seconds of silence. PCIT doesn't do 1 minute per age, nothing like that. The studies show that 3 minutes and 5 seconds of silence is sufficient enough as a consequence, regardless of age.
They have to be quiet the entire time?
No. They can say whatever they want. What happens in timeout stays in timeout chair, but the last 5 seconds they have to be quiet because you want the child to learn that only the silence gets them off the chair. So you wait the 3 minutes and they are screaming and kicking and whatever they do. But then you wait for the child to calm down, and the last 5 seconds have to be silent. And I go over all those rules with the child. I have like a little feelings monster, and I show them with the toy how the timeout is going to look like, so the child knows ahead of time. Once we're done with CDI, you know, how things are going to be different when we enter PDI session. So fair game. The child knows exactly what's going to happen. And the interesting part is, you know, even though we enter the PDI session, PDI part of treatment where they, you know, they still play with the parent, but they also have to listen. Children still really like coming because they love playing with their parents so much. And almost all kids are pretty sad to end therapy, and when they are told, you know, you don't have to come here anymore because you've been listening so good. You know, it's not because they like coming to see me, but it's because they love playing with their parents so much. It's such a huge reward for them. I've been doing it for so long, and it never stops amusing me how much children enjoy interaction with their parents, you know. We have 2 more minutes. We have time for 1 or 2 more questions.
I just had a very quick question, Dr. Romanowicz. Is there a high dropout rate with PCIT or?
Yeah, so that's one issue with that PCIT has. It has pretty high attrition rate. It is pretty hard work for parents. They have to come every week, and they also are expected to practice the skills every day for 5 minutes, which seems like not a lot. We used to call it homework, but PCIT, I realized that it's a pretty negative term, so they changed it into home therapy, but that really didn't change much in terms of compliance of the parents. So it seems like not a lot, you know. So even as you mentioned, Rana, the high functioning parents struggle with finding the 5 minutes every day to practice with their child, you know. And we know there's actually quite a few studies that show that the biggest prognostic factor in terms of how family is going to respond to treatment is how much home therapy they're doing. So that is hard for families, and so they drop out. I haven't had such a huge dropout rate here. I think partially because I've modified the treatment a little bit. I guess that part you guys cut out of the recording. Don't tell anyone. So I shortened the treatment a little bit. That's why it's for the most part 8, sometimes 7 sessions. My teaching, the first CDI and the first PDI session is supposed to be the entire hour, and I shortened the teaching. It's for me anyway. It's families learn sort of on the job, and so I don't know if that help with the attrition. And as you mentioned, we see a little bit higher SES families here. Although I also have families with definitely a lower SES here, and history of trauma and things like that, you know. But yeah, it's attrition is a big issue. And so, for example, motivational interviewing module has been added to PCIT to help with attrition. That's one attempt at helping with the attrition, decreasing it. It's a good question. Well, I don't want you to be late for your next didactics. I'll send you my presentation, and you have the links to videos. Those links actually are to program at UC Davis University to entire PCIT training. So if anyone is interested, you can just kind of look it over. It's extremely interesting, but you can also just look at the videos. Thank you so much. You guys have a good afternoon.
Thank you. You too.